Hey everyone, and welcome. Today, we're going to be talking about acute osteomyelitis. Specifically, we're diving into your role as a pharmacist and how you can navigate these pretty complex therapies to make sure your patients get the best possible outcomes.
All right, so here's our game plan. First, we'll get the basics down, then look at how it's diagnosed. We'll cover that initial IV therapy, talk about that really critical switch over to oral meds, and then wrap up with some essential counseling points you can use every day in your practice. Okay, first up, let's get on the same page. What exactly is this infection, and what are we trying to accomplish when we treat it?
So, what are we really dealing with here? Well, acute osteomyelitis is a serious infection right in the bone itself. And when we say acute, we're talking about patients who have had symptoms for less than 2 weeks. Things like fever, pain, swelling. This thing needs fast, aggressive treatment to stop it from turning into something much, much worse. Our mission here is really threefold, and it's so much more than just killing the bacteria, right? First, cure the infection. Second, we have to preserve function. We're trying to prevent things like loss of a limb. And third, this is a big one, we have to stop it from coming back or turning into a chronic, nagging problem that's way harder to treat. The stakes are just incredibly high. So, with those goals in mind, how do clinicians actually figure out what's going on and, more importantly, identify the specific bug we need to go after? It's a pretty logical path, starting with the patient's history and ending with imaging. But for us, step 2 is everything. Getting those cultures, blood, and especially bone if possible, that is the absolute key. It's what guides our therapy and lets us pick the right drug for the job. And this really drives home a crucial point about urgency. We don't wait around. The second those cultures are drawn, treatment can start. We don't need to wait for the MRI results to come back. It's a fantastic clinical pearl. Act fast once you have those cultures. Okay, so the cultures are off to the lab. While we're waiting for those results, it's time to launch that first attack with empiric IV therapy, making our best guess at the most likely culprits. This table really simplifies our starting options. For osteomyelitis that spreads through the blood, our number one suspect is almost always Staph aureus. So we'll start with a workhorse antibiotic like cloxacillin or cefazolin. Now, the big question you have to ask is MRSA a possibility in my area? If the answer is yes, you're going to add vancomycin to the mix right from the get-go. All right, now we get to the part where you, as the pharmacist, really shine. This is managing that critical transition from IV antibiotics over to oral therapy. And this is the million-dollar question, isn't it? Making this switch has a huge impact on everything: patient comfort, cost, safety. So let's break down what we need to look for to make this call with confidence. I mean, the benefits are obvious, right? You get that IV line out, which lowers the risk of complications, it saves a ton of money, and the patient gets to go home sooner. But we have to balance that with some serious prerequisites. Is the patient stable? Can they actually absorb oral meds? Are there any GI issues? And maybe most importantly, are they actually going to take the pills? Now, this is a fantastic clinical pearl to have in your back pocket. What happens if those cultures come back negative? Does that mean the patient is stuck with an IV for 6 weeks? Nope, absolutely not. If they're clearly getting better on the empiric IV drugs, it is totally appropriate to switch them to a similar oral agent. And finally, let's zoom in on what might be the most practical part of this for your day-to-day work: how to deliver some really high-impact patient counseling to make sure the therapy is a success once they leave the hospital. The first thing you've got to hammer home is the duration. 4 to 6 weeks of antibiotics feels like forever to a patient, especially when they start to feel better after a week or two. You have to make it crystal clear. Finishing the entire course is the only way to cure this and stop it from coming back. Okay, so if you're dispensing a fluoroquinolone like Cipro, you have a huge responsibility to counsel on those serious side effects. They're rare, but they happen. The patient needs to know to call their doctor right away if they feel any tendon pain, weird numbness or tingling, or get super dizzy. With clindamycin, it's all about C. diff. This is a top-tier, must-give counseling point. You have to warn patients to be on the lookout for really bad, watery diarrhea. If that happens, they need to seek medical attention immediately because it could be a sign of a very serious secondary infection. And then we have metronidazole. The number one point here is simple: absolutely no alcohol. You have to explain that they can get super sick, nausea, vomiting, flushing, the whole deal, and tell them this rule applies for the whole time they're taking it and for at least a day or two after they finish. And let's not forget the kids. For pediatric patients, adherence can literally come down to one simple thing: taste. So when a child is switching to oral meds, just remember that liquid cephalexin usually tastes a lot better than cloxicillin. It sounds small, but trust me, it can be a total game changer for adherence. And that really brings us to the main takeaway here. This whole journey, from getting diagnosed to getting cured, is long. It's complicated. And your expertise in monitoring, in counseling, and in just cheering the patient on to stick with it, that's the essential link that bridges the gap between just having a prescription and actually getting a cure.